So I'm Sheina and I'm a fifth year and I'm intercalating in anatomy and human biology. So today I've been asked just to do a bit of teaching on sarcoidosis, hypersensitivity, pneumonitis and IPF. Okay, so to start off with, we're going to talk about sarcoidosis. Now that's derived from the Greek word which means flesh-like. So a bit about the condition. So it's a chronic multi-system granulomatous disorder of an unknown cause. Commonly affects the lungs, skin and eyes. So it can affect virtually any organ, but generally it begins in the lungs, the skin and the lymph nodes as well. Less commonly it can affect the liver, the heart and the brain. So it's characterised by the accumulation of lymphocytes and macrophages, which are immune cells, in addition to the formation of non-caseating granulomas in the lungs and the other organs, as I've mentioned. So in over 90% of cases, it affects the lungs and the lymph nodes. And it follows a bimodal age of distribution with a peak in the third and the fifth decade. And it's generally a diagnosis of exclusion, as you'll see in the investigation section. So some risk factors, being 20 to 40 years old, family history is a big one, being of Scandinavian origin as well as African American. And in African American individuals, the disease generally follows a more severe and chronic course. Okay, so some pathophysiology. So as I mentioned before, there's non-caseating granulomas, and these have multinucleated giant cells in their centre. So it's an immune response. They're formed in response to an unknown stimulus, which induces a local T cell mediated response. So these contains CD4 lymphocytes as well as CD8, which cluster around the periphery. Now the T helper to T suppressor cell ratio is increased, and a mass effect from all these granulomas forming is what induces damage in the tissues. And these multinucleated cells generally arise from the fusion of both macrophages and monocytes. So due to this chronic stimulus, these inflammatory mediators lead to accumulation of Th1 helper cells at sites of inflammation, and that contributes to the granuloma formation and structure. So some signs and symptoms. So cough, which is generally non-productive. Dyspnea, which is of gradual onset. You can also get wheezing and rhonchi, which is due to the airway hyperreactivity. So the lung involvement is generally in about 90% of cases, but in about 50% of cases, it may be asymptomatic and an incidental finding just on a chest X-ray done for another reason. Some systemic symptoms include chronic fatigue, unexplained weight loss, a low-grade fever, as well as anorexia and night sweats. Also arthralgia, so joint pain, which can commonly be in the knees, the ankles and the wrists. Lymphadenopathy, due to the involvement of the lymph nodes, and that's generally the cervical and submandibular nodes, and these are non-tender. Uveitis is the most common eye manifestation, and that can present with photophobia, red painful eye, as well as blurred vision. And then some common neuro signs and symptoms include seizures and headaches. You can also get hepatomegaly, and the most common cardiac manifestations include conduction abnormalities such as arrhythmias and heart blocks. Some skin involvement includes erythema nodosum, plaques, and lupus pernio, which is raised hardened lesions on the skin of purple colour, and it's pathognomic of sarcoidosis. The acute presentation of fever, arthralgia, and erythema nodosum is known as Lofgren syndrome. This is just some pictures showing some of the lesions, as I've mentioned before. Okay, so some differentials. So just some granulomatous diseases, infections, hypersensitivity, pneumonitis. There's a range of rheumatological syndromes which can cause similar syndromes, lymphoma, IPF, which I'm going to discuss a bit later, asthma, and TB. Okay, so some investigations you might want to do. So chest X-ray, bloods, so full blood count, looking for anemia and leukopenia. Urinase, so in renal involvement, you can get a raised urea and creatinine. LFTs, that might show elevated AST and ALT if there's liver involvement. Serum calcium is important because you can get a hypercalcemia from dysregulated production of calcitriol. That's by the activated macrophages and the granulomas. Pulmonary function tests are important. So these may show either an obstructive or restrictive pattern, or it can be a mixed pattern. And the forced vital capacity, the FVC, is important to monitor disease progression. So if you've got a decline, then that would indicate a progression of the disease. An ECG, looking for the conduction abnormalities. Purified protein derivative of tuberculin, that's to rule out TB, and that would be negative, obviously, in sarcoidosis. You might want to do a CT chest, a flexible bronchoscopy with biopsy. So the biopsy would show non-caseating granulomas. Skin biopsy as well. Endobronchial ultrasound, aspiration. It's also to do histology, and then serum ACE. So levels are often raised in sarcoidosis, but it's not a very sensitive test. So some chest X-ray findings, as I mentioned before, so that can be staged depending on where the disease is at. So stage 0, that would be normal. Stage 1, you'd get bilateral hilar lymphadenopathy. Stage 2, you'd get the same as stage 1 with pulmonary infiltrates. Stage 3, that would be the pulmonary infiltrates, but no bilateral hilar lymphadenopathy. And then stage 4, which is obviously the worst, that'll be extensive fibrosis with distortion. So the management of sarcoidosis, so treatment varies. Most often only require symptomatic treatment with NSAIDs such as ibuprofen and aspirin. So first line management, that's generally given for stages 2 to 4 for the lung involvement, and that's usually with oral corticosteroids. Some second line options include methotrexate, which is an antifolate drug, and that inhibits dihydrofolate reductase, and that's generally given weekly. Azathioprine, which is an immunosuppressant that blocks purine synthesis, which is required to produce DNA and RNA, and then hydroxychloroquine, which is an anti-malarial drug. So oxygen therapy may be needed, and that's generally if that's dropped below 88 or the PaO2 goes below 55. And then lung transplant in extreme cases that don't respond to the previous management options. The prognosis is generally good. So in about 60% of people, the granulomas disappear over about 2 to 5 years. But in some, the disease can remain active or just reoccur intermittently. Okay, so hypersensitivity pneumonitis, that's the next topic. So that's also known as extrinsic allergic alveolitis. So it's a result of non-IgE mediated inflammation. It's caused by repeated inhalation of a non-human protein or the result of a chemical conjugated to a human airway protein. So the protein can be of natural plant or animal origin. So people are often exposed to these by dust and mold in their job or hobbies. And many cases only develop after many years of continuous or intermittent inhalation of whatever's triggering it. So the inflammation manifests in the alveoli and the distal bronchioles. So some causes, so there are many, often it's occupational. So there's a range of different, so bird fanciers and pigeon fanciers lung, farmer and mushroom workers lung. So the bird fancier, that's often proteins in bird droppings. Then you've got malt workers lung, sugar workers lung. There's a range of others. There's a long list of different names for the conditions. And then some drugs such as nitrofurantoin, methotrexate and rituximab can cause a drug-induced hypersensitivity pneumonitis. The most common ones are generally bird fanciers and farmers lung. So a bit about the pathophysiology. So it develops over hours following exposure. There's a cellular infiltrate, which consists generally of lymphocytes, plasma cells and neutrophils. Also non-caseating granulomas, as well as some macrophages. So it can be split into different phases. So in the acute phase, that's 4 to 6 hours after exposure to the antigen, and you get poorly formed non-caseating granulomas, as well as a monocellular, mononuclear cell infiltration with giant cells. Then you've got a subacute phase, and that's generally weeks to months after exposure, where the inflammation isn't as severe, but there's often a fair amount of fibrosis, which can result in a more insidious development. The granulomas that are formed here are more formed, and you can also get some interstitial fibrosis. And then in the chronic phase, that's generally months to years. There's little inflammation, but it's characterised by a lot more fibrosis. Now the pathogenesis involves both the type 3 and type 4 hypersensitivity reaction. Type 3 being the production of immune complexes, and type 4 being a more delayed response that's mediated by Th1 helper cells. Some signs and symptoms. So in the acute phase, which is, as I mentioned, for about 4 to 6 hours post-exposure, you can get fever, rigors, myalgia, so muscle pain, dry cough, as well as dyspnea with fine bibasal crackles and auscultation, a rash, as well as swelling. In the subacute phase, you can get similar symptoms to the acute phase, but it's often less severe but lasts longer, so more gradual development. So you can get a productive cough, dyspnea, fatigue, anorexia, weight loss, and pleurisy, which is just inflammation of the pleura, which lines the chest cavity. And then finally, in the chronic phase, you get a cough as well. That's more an insidious onset. Clubbing you can get increasing shortness of breath, as well as on exertion, fatigue, weight loss, cor pulmonale, which is where you get hypertrophy of the right ventricle, which is from lung disease that results in pulmonary hypertension. And then you can also get type 1 respiratory failure, and that would give a hypoxemia. So many will also have hypoxemia. So as well as at rest, they may desaturate with exercise. So just some differentials. So bacterial pneumonia, asbestosis, good pastures, IPF, granulomatosis with polyangiitis, miliary TB, and sarcoidosis. Right, so just some investigations. So for the acute phase, you do some bloods. So a full blood count, which might show a neutrophilia. It could also show a normocytic normochromic anemia. You might want to do an ESR, which when raised indicates inflammation. Serum antibodies, so you're looking for an immunological response to the causative agent. You'd want to do a chest x-ray looking for upper zone mottling. In rare cases you can get a hilar lymphadenopathy as well, but it can be normal in some people. And between episodes as well, it can also be normal. And then in the chronic phase, you do the same bloods as well. And then you might also want to do lung function tests, looking for a restrictive defect. So in the subacute or chronic phase, there may be a mixed picture with both obstructive and restrictive features. So going back to the LFTs, that can sometimes show a low albumin. And now high resolution CT is more accurate than a chest x-ray. And so it can show different things in the different phases. So in the acute phase, you can get a non-specific ground glass opacities involving the lower lobes. Subacute, you can get diffuse micronodules with a ground glass appearance, as well as some thin-walled cysts. And then in the chronic phase, you can get these nodules with ground glass attenuation, fibrosis, and honeycombing. So this is just a chest x-ray, which shows the reticulonodular opacities in both upper lobes. So yeah, so the different phases, as I said before, can show different things. So in the acute phase on a chest x-ray, it can often be poorly defined. Then in the subacute, that's quite similar, with a predominant reticulonodular pattern. And then the chronic, you get progressive fibrotic changes, and you can get a loss of lung volume and coarse linear opacities. And then in chronic hypersensitivity pneumonitis, this is just a chest x-ray and a high resolution CT, just showing some of the changes. So on the chest x-ray, there's some ground glass attenuation, and areas of low attenuation with fibrosis. And then in the CT, that then shows the fibrosis and the nodules. Now on to the management. So really important to hypersensitivity pneumonitis is avoiding whatever's causing the symptoms. That's generally the best management option. So some things that can be done in the environment include reducing the humidity and improving the ventilation. And then if it's occupationally related, then removing that person from the job, which can often be damaging if that's their income. And then oral corticosteroids can be really effective, and they can improve the symptoms as well as the lung function, generally given in acute and subacute cases. So that's if the environmental interventions aren't working. And they can be tapered over about 6 weeks. But in chronic cases, they may be required at a low dose long term. And the acute symptoms just generally resolve upon cessation of exposure, as I said before. So yeah, so acute symptoms generally resolve within about 12 to 48 hours. Okay, and then now on to idiopathic pulmonary fibrosis. So a bit about the condition. So it's a rare chronic life-threatening disease characterized by the formation of scar tissue in the lungs, as well as progressive shortness of breath. It's the most common of the interstitial lung diseases. In the UK, it affects about 14 to 43 people per 100,000. It has a very poor prognosis of about 2 to 5 years from diagnosis, and it's of unknown cause. So some risk factors. So generally it's associated with older people, so most are over 60 when they're diagnosed. There's a male predominance, as well as family history. And then there is some association with cigarette smoking, as well as GORD, so acid reflux. So a bit about the pathophysiology. So irrespective of whatever risk factor, there's a resulting injury which triggers the immune system and leads to an inflammatory and fibrotic response, and that causes an influx of some immune cells like macrophages, as well as the fibroblasts, and they persist. So there's a dysregulation of normal tissue repair, and importantly, there's formation of this fibroblastic foci, and due to this dysregulated process, there's continued deposition of extracellular matrix proteins, and that leads to progressive fibrosis. So this all leads to destruction of alveolar destruction, as well as infiltration of the interstitial space by this fibrosis, and that damages the lung parenchyma. Okay, so some signs and symptoms. So exertional dyspnea, that's the most prominent symptom, can be very disabling to people. Cough, which is often on exertion as well, and can be severe. It's usually non-productive and isn't responsive to antitussives. On auscultation, there's fine end inspiratory basilar crackles, which are Velcro-like. It can lead to weight loss, as well as fatigue, malaise, clubbing, yeah, okay. So just some differentials. So hypersensitivity, pneumonitis and sarcoidosis, as I've mentioned before, as well as pneumonia of varying causes, COPD, and asthma. So some investigations. So chest x-ray, so most people will have an abnormal chest x-ray when they're diagnosed, and that can show basilar, peripheral, bilateral asymmetrical reticular opacities. High resolution CT, and that's important for all patients, as it's the most sensitive to picking it up, and that can show basilar and subpleural areas of increased reticulation, as well as a honeycombing and bronchiectasis. Pulmonary function tests will show a restrictive pattern with a reduced forced vital capacity, as well as a reduced transfer factor. Bronchoalveolar lavage, and that may show activity of alveolitis. It may show increased lymphocytes, which would suggest a good response to treatment, or if there's increased neutrophils and eosinophils, that would suggest a poor response. ANA, so anti-nuclear antibodies, that can be elevated in about 10 to 20% of people. It's generally only mildly though. Rheumatoid factor, that can be positive in about 10%. Lung biopsy may be required for diagnosis, and that would show the histological changes of usual interstitial pneumonia. And ABGs may show decreased PaO2, and if severe, increased PaCO2. So this is a chest x-ray showing the opacities, as I mentioned before. And the high resolution CT showing the reticulation, honeycombing and bronchiectasis. And then a bit about the management. So the recommendation is generally to avoid high dose steroids, except if the diagnosis is in doubt. Some first line options, so pirfenidone, that has anti-inflammatory and anti-fibrotic properties, and that's been shown in studies to improve life expectancy when compared to supportive measures. So by reducing the lung scarring, it reduces the disease progression. There's nintedanib, which inhibits growth factors, 3 growth factors, so PDGFR, FGFR and VEGFR, and they're all involved in the fibrosis. So by inhibiting them, you'd preventing the fibroblast proliferation. Now, supportive measures which are very important, and that includes stopping smoking if they're a smoker, pulmonary rehab, and then oxygen if required. And then in severe cases, lung transplant. And it's good to get palliative care input as well, especially considering the poor prognosis. So 50% only survive 5 years, so it's very important. Okay, I think that's everything. If anyone has any questions.
Thank you. I'm just gonna add the feedback form now. 1 second. And if you could please fill it in. There you go. And if you could please fill it in to get the feedback forms. Thank you very much. If there's any questions, just pop them in the chat as well.
I'll send over the slides so that there. Okay.
Okay. No, it doesn't seem to be any questions. Well, so as I said, yeah, just please put in the feedback. Just helps you now, and just so you can get access to the slides as well. Thank you.